Hello, my name is MANTU GUPTA. I'm the Chair of Urology for Mount Sinai West and Morningside Hospitals. It is my pleasure to talk to you today about ultrasound access for PCNL. Thank you very much for inviting me to your Congress. I'd like to thank Dr. Caballero for the invitation, Dr. Smith for the opportunity to speak, and Dr. Portillo for chairing this session. Ultrasound-guided PCN renal access is becoming more and more popular in the United States and elsewhere. The prerequisite for performing ultrasound access is that you have a transducer with ultrasound frequency from anywhere from 3.5 to 5 megahertz to allow visualization of the kidney. This monitor must be equipped, or is preferably equipped, with an electronic dotted line, especially for beginners, that guides the needle movement. This should be a convex transducer of roughly 3.5 megahertz, preferably the smaller size for better mobility, focused at 7 to 9 centimeters depth. The advantages of ultrasound-guided PCNL renal access are many. First of all, it's readily available, portable, and inexpensive. There is no or minimal radiation exposure while planning the access. It provides guidance for access in multiple planes, longitudinal, transverse, and oblique. You have real-time imaging of the collecting system with better delineation of both the anterior and posterior calyces compared to fluoroscopy. There's also real-time monitoring of the needle tip during the puncture, again, without using radiation. There's also improved visualization. You can avoid injury to adjacent organs such as the colon, spleen, or liver, and you can also see the pleural reflection and avoid hemothorax, hydrothorax, pneumothorax, even though the incidence is very low. Potential to avoid vascular structures is also there by using Doppler and color. This is an example here of visualizing the kidney in the longitudinal plane. You can see the entire kidney from upper pole to lower pole, see the calyces and see the stone all in one shot. And this is how the transducer is usually held in the prone position, almost along the pattern of the ribs, along the rib cage, along the 12th rib especially. If you wanted to see the transverse view for a better shot at the one particular pole, for example, the lower pole when you're doing your access, all you have to do is turn the transducer more into the horizontal plane. So it's no longer along the path of the ribs, but facing medial to lateral. The non-dominant hand holds the probe, and the dominant hand holds the needle for better and more secure access. The needle and ultrasound probe should be aligned with the renal axis and should also be aligned with the skin. If your transducer is not perpendicular to the skin, then you will not see the needle move as you are expecting to do. Also, a mild in and out movement of the needle helps to align the needle to the end calyx. Holding respiration when advancing the needle may also facilitate the needle placement in the calyx, as the kidney will stop moving. As demonstrated here, there's less movement when you hold respiration, and then you can advance the needle under real-time guidance. And you can see the needle here going through the fascia, capsule, and now puncturing to the stone, finally, in the proper plane with very little movement.
So this is the office renal ultrasound, and you can see this is the left kidney, and we found hydrocalyces in the lower pole. You can see a dilated calyx here, and a dilated calyx here, and another dilated calyx down here. So all three lower pole calyces are dilated, and there's a stone here in the lower pole, measuring about 5 millimeters, and a larger stone here that we could just see the tip of that looked like it was in infundibulum between the lower pole calyces and the renal pelvis. And then also in the imaging we saw another stone that was higher up, but it did not appear to be causing hypernephrosis. So we proceeded to order a CT scan, non-contrast, of the abdomen and pelvis. And these are the findings. We do most of our CT scans in prone position. And we like to do prone position, especially if we're planning surgery on a patient, because it gives an idea of where the pleura is relative to the kidney, and where the liver and spleen and the colon lie relative to the kidney, so we can make sure there's a clear access track to the patient's kidney. So you can see here in the upper pole already of the left kidney, there's a relatively sizable calculus. There is mild hydronephrosis around it. You can see this irregular calculus, sort of amorphous, with a secondary stone in another upper pole calyx, but there's not much dilation of the upper pole calyx. And then extending to the renal pelvis, you can see there's a renal pelvic partial staghorn type stone here, extending all the way down toward the lower pole and probably obstructing the lower pole as we had seen in the office on the ultrasound. And in the lower pole there's hydronephrosis with the hydrocalyces. You can see the 3 calyces here with a lower pole stone. This is the same one we saw in the office. You can also look at is the skin to stone distance, and we can measure that to the posterior lower pole calyx, which is normally where we do access for a case like this, realizing that a second access may be necessary to the upper pole. You can see here the pleura is coming down pretty low, so there's a high chance of pleural injury if we have to go above the 11th rib. Trying to go below the 12th rib would probably not be a problem going to the lower pole, but would be if we wanted to go to the upper pole, because the 12th rib is here, and we'd have to go intercostal, which would increase the chance of a pleural injury. So in a case like this, I would normally prefer to go lower pole posterior with my access, and then get this stone out, and then look toward the renal pelvis for getting this stone out, and then if possible getting to the upper pole. If not, using a flexible nephroscope to try to retrieve these stones or move them into the renal pelvis, and if they appear to be too large or not amenable to a laser, at that point doing a secondary access into the upper pole to remove these stones. So that's our general approach, and you can see with the colon's not in the way, and so relatively short skin to stone distance, which we can measure here. To this calyx, the distance is only 6.3 centimeters, so a very short distance to get to this kidney. So I start with an ultrasound here, and you can see the entire kidney horizontally. You can see the staghorn stone here, and you can see the hydrocalyces in the lower pole. You can see here's the more anterior calyces. There's a posterior calyx right there. We're going to try to guide our needle into this posterior calyx right there, because that'll give us good access to the staghorn. So, I use a needle guide here. Put that on, and make that posterior calyx. Okay, the other needle. Okay, so we're not going to even go in, but that's not. So I want to this. Alright. You see the fluid coming out, so we've got a nice puncture into that posterior lower pole calyx. Here's the angled guide wire. I use an angled, this is a sensor wire that I like to use. It's nice because it's hydrophilic at the tip, and yet the shaft of it stiff enough that allows dilation relatively easily. So we'll put that in, get some nice clear fluid. We'll go to the fluoro image. So this is our needle in the collecting system. You can see on the fluoro image that a guide wire is pointing in those lower pole calyces, which is fine. It's not wanting to go past the staghorn that's obstructing the lower pole. I don't try to force it there. I leave it there, and I do my dilation right into those calyces, so we can get that lower pole calyx stone out, and then get to the staghorn of the renal pelvis.
So ultrasound's not only good for prone PCNL, but it's also got several advantages for supine PCNL, and I'm going to go over some of those advantages here. First of all, the supine position is becoming more and more popular in the US and in Europe and elsewhere. The disadvantage traditionally of the Valdivia position, the original Valdivia position, is that there was no retrograde access to the ureter, especially in the old days of semi-rigid ureteroscopy, and the saline bag that was used hampered nephroscope mobility. But the modified Valdivia position in lithotomy also was better for access retrograde, however, created strain on the contralateral calf and ankle, and ipsilateral calf, thigh, and ankle, and many patients had postoperative pain and neuropraxias. The GUPTA modification of this position was used to first simultaneously treat both renal and ureteral stones, especially in cases of large ureteral stones and Steinstrasse, where semi-rigid ureteroscopy could be done first, and then you didn't have to flip the patient. You could go right to the percutaneous access and remove the stones. The advantages are that you can get through and through access, pulling the guide wire placed antegrade into the bladder and out through the urethra. That's secure access. Retrograde access to the ureter for migrated fragments. And the air in the bag that was originally used for the GUPTA position could be adjusted for access to the anterior calyces and the posterior calyces, depending on the amount of air in the bag. This is, however, the position that I have come to use. This is called the Bart's flank-free position. And it's got advantages of the Valdivia position and GUPTA position where you have access to the urethra. Now, in the old days, we used to use rigid cystoscopes, rigid, semi-rigid ureteroscopes, but now we're using flexible instruments, flexible cystoscope, flexible ureteroscope. So there's no need anymore for the patient lithotomy. The rationale for this position is you have more space for the nephroscope because you have more space in the flank, and there's less pressure on the extremities. This is how we position a female. Again, the genitalia is still accessible, as you can see in this image, and you have plenty of space to operate in, unlike the Valdivia position where the rib cage is close to the hip. There's more separation here. We mark the posterior axillary line, the iliac crest, and the ribs, and we try to stay below the posterior axillary line. There's more space between the ribs and the crest in this position, and you only need 10 to 15 degrees of tilt. We have found that more than 10 to 15 degrees is counterproductive for the vortex effect as well as for gravity. Advantages of supine position is there's no need for general anesthesia or intubation. It can be done with spinal or with laryngeal mask airway. There's no need to paralyze the patient, and the patients therefore recover more quickly. There's less risk to the patients, and they can be done as an outpatient procedure, as 90% of our patients are now done. You can also access the anterior and posterior calyces both, and the fragments come out by gravity or vortex. It's a low-pressure system, and there's less chance of colon injury, as several studies have shown. Also, again, advantages include less radiation, end-on view of the calyces, precise needle placement in real time, ability to follow the infundibulopelvic angle, so there's less torque on the kidney, and ability to visualize surrounding structures and not injure them. So the combined supine PCNL and ultrasound has the advantages of ultrasound-guided PCNL and supine PCNL, combining everything in one. And this is a sample case I'm going to show you here. A 65-year-old female presented with stones, past medical history of hypertension, gout, and nephrolithiasis. On CT, she was found to have a large stagone with several small stones and severe hydronephrosis and cortical atrophy. In addition, she had a 4 millimeter right renal stone. And this is a CT image of what the stones look like. It was a 1.9 centimeter by 1.5 centimeter partial pelvic staghorn stone on the left side. And the plan was left supine mini PCNL. And you can see the view of the kidney here. And in the inset, you can see us placing the needle through the ultrasound probe. And you can see how easy it is to visualize the calyx. And you can see the puncture right here, the needle going into the collecting system, and the fluoro image showing the dilation. So very easy to access a hydronephrotic kidney. Here's a second case, which is slightly more challenging, and I'll show you what we did here. It's an 80-year-old Caucasian female who presented with sudden left flank pain after a fall. And this is what her CT scan looked like. You can see there's some hydronephrosis, some small calyceal stones, a large renal pelvis stone that's about 2 centimeters in size. And you can see she has quite a bit of a fat pad behind the kidney there. And so in this case, we wanted to do supine PCNL because it allowed us a more direct access to the kidney. This is the coronal plane CT scan. Again, you can see, yep, we want to avoid the upper pole.
Welcome everyone. I just wanted to show you the position I use for supine PCNL. This is my modification of the Bart's flank reposition. Basically, we have the ipsilateral leg straight, the contralateral leg at a slight bend. It's a very comfortable position for the patient. Here the patient tilts in just about 10 to 15 degrees. It's not much of a tilt. As you can see, the patient's almost flat, with a little bump right here at the shoulder, and another bump here at the hip. And actually on the leg, the thigh, not really on the hip. You want her to rotate, just a little bump there. And then we draw our markings. So either the 12th rib, the 11th rib, the iliac crest, and the posterior axillary line down the anterior superior iliac crest. So that's the mark where we want to stay with our access, if at all possible, below that. I find that sometimes if you're doing anterior access, you're going down more, and it might be a little bit above this, but you really see any bow if you do that. If you're doing the posterior calyx access, it will go like this. This is our general position. We have the arm clear pointing over to the other side. And we have some nice padding that we do to keep everything nice and padded. You can see the padding we also put in the knees, and the foam we put in the legs. Position. Most of the time we can do an LMA in certain situations we may want to do an intratracheal intubation, and the majority of these patients are going home the same day.
So here we're doing the initial cystoscopy, placing a guide wire, and we use an occlusion balloon. In this case, this patient had a ptotic kidney. You can see that the kidney was falling down, and you can see the large pelvic stone obstructing the UPJ. So here's the occlusion balloon going up. And in this case, we found in these ptotic kidneys where they're sagging, especially an older female like this, which may not have the best, she may not have the best tissues, laxity of the tissues in the flank, the occlusion balloon actually can be used, as in this case here, to straighten the kidney out. And you'll see occlusion balloon going up, and we pull the kidney down, and that sort of straightens it. And it fixes the kidney in place and makes it easier to do ultrasound access once the kidney's fixed in place and not as mobile. And here you can see our transducer that we're using, the needle guide and the needle. And this is our ultrasound image here. You can see we start with a longitudinal view, so we can see the entire kidney, upper pole, middle, and lower, all the calyces. We map out the collecting system, see where the stones are, see where the calyces are, decide on an anterior or a posterior calyx. And you can see our needle going in right there into that posterior lower pole calyx. You can see clearly the needle tip in the collecting system. Very easy access when there's any degree of hydronephrosis. You can see we're right there on that posterior axillary line. And there's our guide wire going in. Now, because our axis is lined up for the infundibulum, so we can go right from the calyx into the renal pelvis pretty easily. You can see here our guide wire goes right into the renal pelvis, no issue at all, because we lined it up with ultrasound. Whereas with fluoro, you're never quite sure what angle you're getting into that calyx, and you're not sure it's a good trajectory or not to get to the renal pelvis. So ultrasound, there's almost never any guessing. So in conclusion, ultrasound provides the best access for PCNL, in my opinion, due to there's no guessing what calyx is best, anterior or posterior. Especially with supine position, you can choose anterior or posterior, but you can also clearly see what's anterior and posterior. Whereas with fluoroscopy, sometimes some of the calyces are hidden. They don't always get filled with contrast or air, whatever you're using for your pilogram, and you don't always see all the calyces. But with ultrasound, you can see every calyx all the time. You can also visualize the entire collecting system and all stones, even radiolucent ones, which aren't seen on fluoroscopy. You have inline access to the calyx, allowing for maximum stone removal. Because you can go easily from the calyx to the renal pelvis, you can also go from the renal pelvis to other calyces, either with the rigid nephroscope or the flexible nephroscope, and get all the stones. And because there's less torque and bleeding because you're in line with your access, you'll have less need for blood transfusion. There's also less radiation exposure to the patient and the surgeon, and to the anesthesia and OR teams. And there's easy targeting of both the anterior and posterior calyces for supine PCNL, as I mentioned before, with a better vortex effect when you're using supine position. So I'd like to thank everyone for their time and attention. Thank you very much for allowing me to participate in your Congress.